So thank you for coming today. We're so thrilled and excited to have Dr. Cook with us. Dr. Cook has been doing this with us for several years, and the topic he's talking about today is one that is really in the spotlight because we get a lot of questions and inquiries about gastric neurostimulation, but there's still a lot of those in the medical and patient community who really are unaware of it. So we're going to take care of that today. Well, Dr. Cook is going to take care of that today. My name is Mary Angela De Grazia De Tucci. I'm a longtime patient with multiple digestive motility disorders, including gastroparesis. And I am humbled to volunteer for the Association of Gastrointestinal Motility Disorders, or also known AGMD. We serve as an educational resource for digestive motility disorders. We also serve as a clearinghouse for those in the medical, scientific, and nutritional communities. And of course, we are a form of support and education for patients and their families. Dr. Cook, thank you as always for being here today. Can you tell the audience a little bit more about your background and then tell us about gastric neurostimulation?
Yes, thank you so much for having me today. And hello, everybody. I'm glad you've joined us. Yeah, as you can see, I was at Wake Forest for many years, and 20 some, and at Penn State before that. My entire career I'm a gastroenterologist. I was always interested in what is nausea, how do we treat gastroparesis as part of the NIH Gastroparesis Consortium for over 15 years. And more recently, I took a detour here. I'm the medical director at Entera Medical, which I had used this device in the past. I had prescribed it, and it's a gastric neurostimulator. And so it was one of the treatments we would use when our drugs were not helping, especially with symptoms like nausea. And so today, Mary Angela invited me to talk about gastric neurostimulation for patients with gastroparesis. So here we go. I've got about 20 some minutes to talk, and then we have lots of time for your questions. This is a humanitarian device. It was approved over 20 years ago for patients 18 to 70, mainly for nausea, predominant gastroparesis symptoms. The FDA appreciated there was no good treatment for people with drug refractory nausea. And at that time, they didn't go through the usual process of approval. It was approved because it had minimal side effects and really could help, based on published literature, the patients with gastroparesis, as I mentioned. So today we're going to talk about the normal stomach in terms of its motility and compare that with the gastroparetic stomach. If you have gastroparesis, your stomach does not work right, as you know. And so we're going to go a little deeper on that question. And then I'm going to look at the management of gastroparesis, a brief overview, because I'd like you to see where the gastric electrical stimulation fits in. And then we're going to talk the second half about, well, what is it? And we call it gastric electrical stimulation. The company calls it enterotherapy. And so we'll talk then, focus on how it works, what it does for chronic nausea and vomiting. So normal neuromuscular work of the stomach after a meal. So there's three things your stomach has to do when you ingest a solid. Liquids are a little easier. As you all know who have gastroparesis, liquids can be more tolerated than a solid. So in response to swallowing a solid chunk of food, the stomach first has to accommodate it. That means it has to relax, it has to receive it. And then it has to triturate, which is a fancy word for mixing and milling, mixing and milling. Stomach needs to do that work to prepare the meal for emptying. Emptying is when those nutrients are emptied from the stomach into the duodenum, so the particles can begin to be absorbed to become ourselves. It's crucial for nutrition. And so when you're healthy, you are truly rewarded for finding food. If your stomach is empty, at least if mine's empty, I'm getting hangry. The fridge hopefully is close because once I begin to eat and begin to relax my stomach and fill my stomach, I feel great. It's very satisfying, comforting. And this is the way it's supposed to be when the stomach's working right. So there's the fundic relaxation. It's relaxing to receive. Here's the corpus antrum is the workhorse of the stomach, where these big particles are being milled into little tiny particles. That happens because we have peristalsis. Peristalsis is that moving contraction. I'm showing that narrowing there. That's a contraction. And as that contraction moves over the particles, they get milled into little tiny particles. Actually, nothing leaves the stomach till it's a millimeter or two in a suspension. It has to be like a Newman's Own salad dressing. You shake it up, there's particles. Well, when the particles are small enough, one of these contractions will eject, 2 to 4 milliliters. It's not a huge amount. That's why it takes time to empty a meal. It depends on the calories and what's in it, but it takes time for this process to work on the food we ingest. So these are the aspects of the anatomy and physiology related to normal emptying of food. And these contractions, especially the peristalsis, are so crucial that the work of the stomach, it is rhythmic. Those peristaltic waves are not helter-skelter, they're rhythmic. So how do they have rhythm? They have rhythm because the stomach has a pacemaker. Pacemaker region is on this area, on the greater curve, we call it. And the pacemaker region produces, here's the magic number, 3 cycles per minute. 3 cycle per minute pacemaker waves, they're called slow waves. Why slow wave? Because they go around the stomach fast, but it takes them 20 seconds approximately to migrate to the pylorus. And as one wave is finishing up down here at the pylorus, another one is beginning. So it's like waves coming into the shore. You see one crashing at the shore, but there's also another one starting out in the distance. Over and over, this is what controls what actually creates the peristalsis and the contractions that are linked to these pacemaker waves. So it's a critical feature of normal stomach motility after we eat. So here's in one slide, we know over 20, 25 years of research in gastroparesis, yeah, good activity goes bad. And instead of good relaxation, you have poor relaxation. Can be throughout the stomach. All the stomach has to relax to some degree to create a good peristaltic wave. Here I show, poor fundic relaxation. The good 3 cycle per minute stomach rhythm is replaced by irregular stomach rhythms called dysrhythmias. There's less of the normal 3 cycle per minute rhythm. And so you're going to get poorer, weaker, irregular contractions. The pylorus can be in spasm. You'll see we do endoscopy when you have gastroparesis to make sure there's not an actual stenosis there, a scar. But the pylorus can be in spasm where it's a bit tight and restricts that flow. So, over the years, we know that if this fundus doesn't relax, people tend to get full right away. I mean, you can fill up because your stomach is relaxing. When you feel full right away, that would go along with a poor stomach relaxation, early fullness. There's a lot of research that shows an irregular rhythm is associated with nausea of pregnancy, nausea, motion sickness. Almost two-thirds of our patients have a dysrhythmia. And then if you don't have good contractions, the food tends to sit there. So many patients say, I've got a brick in my stomach and I ate 4 hours ago. That to me is that food is sitting there. It's not being milled. It's not being emptied. So that's in a nutshell how um, disturbed the stomach can be. And then the vagus nerve, you might know the name. Vagus is a major nerve that controls the stomach, and it takes a lot of information upstairs. So upstairs is your brain, upstairs is your cortex, and you say, no, wait a minute, I just ate. I'm not happy. I'm not comfortable. I'm uncomfortable. For all these symptoms, which you all are aware of. And so, in fact, here are the symptoms associated. Now, they're associated with slow emptying, just the overall, it's emptying slow. And over the years, we've put all these symptoms, we've laid all these symptoms on slow emptying, and we gave it a fancy name, gastroparesis. So, most patients have some degree of nausea, as you know, bad nausea. I mean, mild nausea is bad enough, but bad nausea often crescendos to vomiting. Vomiting is usually kind of undigested food. It hasn't been milled. In patients with gastroparesis, there's the early satiety and the postprandial fullness that can go on and on. Pain, I put in parentheses because pain can be from so many different things. You really can't pin pain on the stomach until you've done the endoscopy, gallbladder's okay, pancreas, there's a lot of abdominal organs that can cause abdominal pain. So I always kind of highlight, are you sure it's from the stomach? So how do you diagnose gastroparesis? You see your doctor. Those of you who have the diagnosis did a history, physical exam. Doctor makes sure, it's not your gallbladder. It's not an ulcer. It's not heartburn, GERD. And upper endoscopy is usually done at some point in the workup. And a doc may say, well, I don't see much. A little bit of redness, normal. And so to diagnose a motility problem, you need more specialized tests. And of course, we have got the solid phase gastric emptying study, solid phase, because it's a solid meal. And that's the test that tells us can the stomach do the work or can it not do the work? And so the gastric emptying test can tell us emptying is normal, rapid, or delayed. And the classic is the egg beaters test meal. And here's an example of a normal person who ingested this 250 calorie solid meal. It's 2 pieces of bread, a little bit of jam, some water. And you can see at time zero, you have 20 minutes to eat the meal. There's the fundus up here. And the food is getting gradually pushed into the antrum. Some is emptying here. Look at it 2 hours. The meal is spread throughout the stomach, maybe half of it or more, is emptied. And at 4 hours, you should have 10% or less in the stomach. The stomach did its work. But this test doesn't tell you how it did it necessarily, because you look at the patient with gastroparesis at 4 hours, you can outline the entire stomach. So it's delayed, but the test does not tell you why it's delayed. Doesn't even come close. So you now know it may be delayed because you've got poor accommodation or relaxing. You may have a dysrhythm problem. It may just be weak. We don't know about the pylorus. So anyway, it's a marker that there's a problem in overall weakness of your stomach. And so you do the endoscopy to make sure there's no obstruction at the pylorus. There cannot be an ulcer there. Rare for tumors to be there, um, but scar tissue, some kind of physical, mechanical obstruction is what you're trying to rule out there. So if there's diabetes, you want to get the glucose under control. We've talked in the past about dietary modifications. Narcotics will slow the stomach down, and if it can be possible to uh, reduce that, that'd be great. We know GLP-1 agonists delay the stomach. Um, that can be a problem. And then we go into the classic drugs, prokinetics, antiemetics, and those are the drugs you're on perhaps right now or have tried. And but if you're not doing well, you know, we call these more advanced therapies. Um, and that's where the gastric electrical stimulation comes in. You're refractory to the usual drugs. Hopefully, you won't need a pyloric surgery, and hopefully, you won't need any of like a feeding tube or even more major surgeries on the stomach. Okay, it's a big slide, but this is what we have. Diet. Won't go into that too much right now. Patients adjust their diet. They figure out they cannot eat what they ate before they had this problem and make those adjustments. The drug therapies for these past many years have been called prokinetics. They are designed to increase the rate of emptying. Beat on the stomach. We want to beat the donkey and make it work faster. And you can see they haven't really been it hasn't been a fruitful hypothesis. We still have one drug approved by the FDA. Is that like 46 years ago, 47? I can't do the math. It's such a big number. It's a horrible. You might have been given erythromycin. This was approved in like 1952. So you can see I've tried all of these drugs over the years in research. We've tried about a bunch of everything, and there isn't much out there that works predictably. And so I tried tons of Zofran. I liked dronabinol, mirtazapine, even put scopolamine patches on, and and then we get to the advanced therapies like GPOM, endoscopic cutting of the pylorus, pyloroplasty, and then we'll talk about electrical stimulation. So, there was this study from one of the patient support groups that said, really only 4% of people with gastroparesis were satisfied with their treatment options. And, the docs aren't very happy either. It's an unhappy situation. The docs don't have that much to work with for treatments. And then the patients don't have much to feel better about, and it's not good. So let's go on to this enterotherapy. So it's been around over 20 years. It's implantable. It's designed to relieve nausea and vomiting associated with gastroparesis. And it's called electrical stimulation because it just gently stimulates the stomach with little tiny 1 second, tiny little pulses of electricity. It's not a hammer. It's not a pacemaker. These are gentle electrical signals. So the two leads are placed into the stomach muscle. They're connected to the stimulator, the brains of the device, and there's the mild electrical signals sent into the stomach. There's a programmer that we use to adjust it. So it's like adjusting milligrams, but you're adjusting milliamps, just the intensity of the electrical stimulation. It can be turned off, it can be removed. There really is minimal issues with the stomach. It's quite reversible. So it does take a surgeon to put it in, and it takes 1 or 2 hours under general anesthesia. It can be outpatient surgery or in the hospital. Laparoscopic or robots are used everywhere now, so it's robotically inserted. What's inserted in the stomach itself are two tiny electrodes, about less than a ½ inch long. And there it is. The tip of the electrodes are put into the muscle wall of the stomach. Then the actual stimulator device is placed beneath the skin, below the rib cage, and that's where it can be interrogated and the stimulation parameters changed as needed to help control symptoms. So usually after you recover from surgery, it's usually turned on at surgery, but like a month or 6 weeks later, the surgeon or the gastro will see the patient and see how they're doing. And if there isn't much of a change, that's when the adjustments begin. in the doctor's office. Just takes a few minutes to increase the stimulation parameters. So it may take several of those to get to a state where the patients begin to say, I'm feeling better, I'm eating better. Um, let's continue at the current level because the device has a little battery and the more energy you use, the faster the battery will deplete. But with average stimulation settings, it's 5 to 6 years, I would say, on average, when you'll need a new replacement for the battery. So it's been around. It was in a big company called Medtronic, and the company was, Entera was spun out about 3 years ago. But over these 20 years, you can see 15,000 people have received it. It's 20-year history and many, many publications. I just want to show one. It's the most recent and largest US study from Washington University. And this is a standard symptom score, this GCSI. But let's just look at the nausea and vomiting subscale. And then under that, nausea, vomiting, retching. But look at nausea. The scale is 0 to 5. 5 is very severe. 4 is severe nausea. So on average, this was a group that had 157 with a lot of severe nausea. They all had the egg beaters test. They had delay emptying. It was a very carefully done study. So the best possible patients were selected. And at a year, I mean, this is a tremendous drop. I mean, one is mild. And so they're down to a mild form of nausea. And even better, at 5 years, when they followed up 110 people, there was still a sustained improvement. So I think the other benefit is, postprandial fullness got better. So the stimulation is doing a number of things to help these symptoms. It's interesting, over the years, it has not usually helped the actual rate of emptying. I'll show you what we think is going on in a moment. When their nausea is better, nausea and vomiting is like the number one symptom that takes patients to the ED. Number one symptom that gets you admitted because you're dehydrated and nausea won't stop. It's terrible. And so in the year previous to getting the Entera therapy, 58% of the patients had been in the hospital. But a year later, uh, about 13% had had a hospitalization, a really dramatic drop. And if you imagine if my nausea is better, I'm probably coping better. I'm probably keeping more down and just a lot less in terms of symptoms. And again, sustained. But I think the biggest one, for patients and doctors is that you're feeling better such that you're actually satisfied with this symptom relief. And again, it's in the 80, almost 80% at 5 years is pretty remarkable. And as you're feeling better, different medications, you're just not using them as much. So this was probably one of the best studies of enterotherapy in a large number of patients, US citizens, that has recently been published. How's it working? I won't go into all the details, but in the past, there's about a 20% improvement in this relaxation aspect. And if your stomach even relax 20% more, you get some, I think, benefit from that early satiety. You may still have to watch your diet, but it's better. Um, One study showed a reduction in the dysrhythmia, the overall uh, uh, rhythm of the stomach went from like 5 cycles per minute before Entera to like, 3.6, approaching a more normal rhythm, and a study that showed a little more increase in amplitude of the electrical signal when you got into that 3 cycle per minute. So these are more subtle effects on the bad stomach. As I said, it doesn't really improve the rate of emptying. There have been no studies on does enterotherapy affect the pylorus. But you see, the thought is as your stomach performs better, that vagus nerve is taking stomach I'd say stomach, not gut, but stomach brain signals are more positive. What's being transmitted through the vagus nerve to your consciousness is my nausea is better. And that's, of course, a very good thing. But this is how we think is working. So, a couple misconceptions and facts. Enterotherapy is a pacemaker. No, it's not a pacemaker. A pacemaker hammers the heart. A pacemaker on the heart is hammering. This is not a hammer. This is a massage, a little electrical massage going in there to create this effect. Helps your stomach empty. No, not don't count on that, but it's designed to relieve the nausea, vomiting symptoms. Some people think it's not approved. Well, it is approved under that humanitarian device exemption. Uh, Not covered by insurance, wrong. Most insurers cover enterotherapy. So, is it right for you? We can talk about this a little bit, but it's for gastroparesis, diabetic, or unknown cause, idiopathic. Nausea and vomiting needs to be the predominant symptom, not pain. And so you can ask your doctor about it. And if you have trouble finding your doctor or a doctor who knows about these things, Entera has uh, the five amazing nurse practitioners, PAs who've worked with gastroparesis patients in their clinics over the years, and now they're helping patients who call in and um, have questions. Might they be uh, a patient who would benefit from Entera? There's also patient ambassadors who've had it, who can talk about their experience. And Mary Angela, that's my kind of comments. I'm happy to take any questions or go from
As
here.
always, very thorough, wonderful presentation. I think you answered half the questions we got. But this morning, somebody had submitted a question that I never really thought about. And if you have this enterotherapy and you get like a stomach bug, how does that impact that neurogastric stimulator? Or does it?
Yeah. So it doesn't. The electrodes are very securely in the muscle layer. And right now it runs 24/7. And probably you're going to have to suffer through that viral infection. It's not going to make the virus go away. It's just going to keep doing its job. And like a lot of folks with gastroparesis, if you get like an upper GI virus, it's bad, right? You're going to be hammered for not 2 days, probably 5 days, and climb out of it. And I don't know that it'll help you get out of there quicker, but it will keep doing its job. And I should mention, we're doing some research where people who've already had it, they're doing really well, are doing a study where at night the battery is powered down and to see if we can save battery and reduce that use of battery without really affecting how people feel.
That's excellent. That's good to know. And also, I don't know if this person is here tomorrow. Oh, she is. Tamara,
Yes,
do you
Tamara.
want, oh, I'm sorry.
That's okay.
You want to pose your questions to Dr. Cook regarding the neurogastric stimulator?
I'm not sure if I remember all of them, but one of them is I know Dr. Cook said that um, it's like a little, I guess, a pulse kind of thing. But I was wondering, can you have that implanted in your stomach when you go into like an MRI or a CT scan? Will they let you do those kind of things with it in there?
Yeah, it's a really good question. And up until a couple of years ago, no, you could not. So we got an approval to do head and extremities.
Mm-hmm.
because even that was a problem with some people. We didn't have that approval. But the abdomen, no. Yeah, the abdomen would be cannot be done. We are working to see if we can get an approval for that. But if you needed regular MRI of the abdomen, regular ones, I think that would be a problem. Yeah, you wouldn't want to have that
So
in.
I'm assuming the X-ray is the same, right?
Plain X-rays, CAT scans, fine. Yeah.
Oh,
It's
okay.
it's just the MRI
Okay.
because it would heat up. It heats up anything metal and
Uh,
could damage it. There could be injury. So yeah. So if you needed frequent MRIs or thought you would, you should not entertain the idea of Entera.
I see.
But all the other X-rays are fine.
Uh-huh. Okay. One other question. How long does it take for for the doctors and the nurses, whoever, after you get the device, how long after that do they start cranking it up, like to make sure that the stimulator is actually, like, is it, I mean, some people have heard that when you get this gastric stimulator, it gives you pulses of like electricity. Is that accurate?
Yes, it is. It's like a spinal cord stimulator. You are getting little injections of electricity.
Mm,
And that's why number one, they start it during surgery, but you have to recover from the anesthesia. There's a skin incision where the device, is now in place. And so usually a month later, you're free of all that post-op issues and you're getting back to your baseline. That's a good time to see the doc you see. And at 4 to 6 weeks, if you're not feeling better, begin to increase the milliamps.
mm-hmm,
Now, at the highest level, yeah, some patients will feel a little shocking. Some do. And then you might have to turn the milliamps down. Um, so I like to tell the docs, you're not giving milligrams of medicine. You're giving that's called milliamps. That's your electrical therapy. Sometimes if the dose gets too high of a medicine, what do? You have to bring it down.
mm-hmm,
You should think of the same idea.
mm-hmm. My other question is, how do you know whether Entera therapy might be helpful? Because for me, I've been on a liquid diet for 3 years because I got diagnosed with gastroparesis 3 years ago, and then now it's gotten worse. And I had the pyloroplasty, and that didn't work. And I did some other procedures and some other medications and stuff, and nothing seems to work. But then do you know anything about like feeding tubes and stuff? Because I keep bringing it up saying that well, they know I'm malnourished right
Yeah.
now. And so my dietitian is trying, or two of them are trying to figure out whether or not, what therapies are now left. Because since gastroparesis is they don't have a cure for it. Are they? My one question is, are they still researching it? Because a lot of the doctors that I've talked about gastroparesis with, they don't even know what it is.
Yeah. No,
So
no,
how do you
that's
go about, yeah, how do you go
well,
about like going
yeah.
through treatment if like you're getting pushed away every single time you ask somebody, or honestly don't know what it is?
Yeah, I think some gastros don't know what it is. That's why we're here teaching. We're pleased to be here with Mary Angela and this group because it starts with education. And so, but in general, this is the question for patients with gastroparesis. And if you ask yourself, I have nausea that won't go away. My main problem is nausea and vomiting.
Mhm,
Yeah, I'm full, but I really can't eat because of the nausea. Is the main thing. Then, you're probably I consider a candidate, and that's why those numbers, maybe Mary Angela will send them around or something or I can go back to it because here's the deal. Do you remember my picture of what goes wrong in gastroparesis?
yeah.
It's the relaxation, it's the rhythm, it's the contractions. So when the pylorus is treated, it's not doing anything for the other problems. Does that make
Mm,
sense?
yeah,
They made a cut at at the bottom of the stomach, hoping it would empty better.
right. They opened it up
Yeah,
for me, at least.
but it didn't work.
No, it didn't. At first, I thought it would work, and
Well,
they said it would take a few weeks before I
yeah,
felt anything. But and I was supposed everybody says because of that you get diarrhea and some other problems with constipation and all this kind of stuff. So the one other question I have, I'm sorry,
no,
is that what uh, do a lot of people who have gastroparesis have eating disorders? You didn't mention that in your
no. In my own
presentation.
practice, it was quite rare. I had several patients with bulimia, and they
Mhm,
developed gastroparesis.
mhm,
But you have to be careful about this business because I coached patients who had gastroparesis. I coached them to avoid red meat. I coached them to avoid fresh vegetables because those are so hard to mix and empty.
mhm,
I coached them to eat carbs. So, and the coaching makes common sense because they failed to empty a test meal. They couldn't even empty a simple egg beater sandwich. So, there's this thing called food avoidance problems, and you got to be a little careful because I said, well, wait a minute, my patients, I asked them, I coached them, I educated them about why they should avoid certain foods because for
mhm,
their stomach to put a piece of steak down there was just asking for trouble, right? If
mhm,
your
yeah,
stomach is weak, how are you going to empty a piece of steak or
mhm,
a fresh vegetable? So be very careful, and continue to say, wait, I'd love to eat. I wish I could eat. I'd love to eat. Uh, so that can be a tricky one, but for the most part, patients with gastroparesis learn what will stay down, what won't, and that's what they continue to work on. And sometimes you can come in contact with a dietitian who knows about gastroparesis and can help finesse that diet so you can eat more and eat it comfortably. It's an important part of the equation, right? We want to eat.
Thank you for
thank
that.
you,
By the
thank you.
way, and I don't have it with me, but I'm going to go get it. Dr. Cook, along with a patient, they co-authored a book on the three-step diet, which has been instrumental in so many patients' lives. Um, and he narrowed it down. Well, I shouldn't be speaking for you, Dr. Cook. These three steps. Can you just review that while I go get the book?
Well, I will because this is an important question. And so patients who are very sick and kind of on liquids, I'd say, step one is liquid. Step one is actually hydration, is basically your electrolyte drinks. And I taught people how to, sip every hour if they needed to stay hydrated. But then they have to go get nutrients. And so the next step two was soups. Who doesn't like, chicken noodle soup with a little bit of noodle, a little bit of chicken, some broth? Because now you got some salt and water, but you also got the beginnings of some nutrients. And everybody wants a solid, but I said, look, for the easiest solid to empty is a starch. Mashed potatoes is your poster child. And, chicken, fish. So anyway, Laura Dotson, my co-author, well, she was the first author, put together recipes based on this three steps that were colorful, tasteful. I added the sort of physiology. So it's a funky book. It's part medical, part cookbook. Oh,
Can you see
there
it?
it is.
Can you see it all right?
Mhm.
So, comforting your uncomfortable stomach, a companion for the sufferers of nausea and vomiting. Highly recommend it. It's good for not only gastroparesis, but I used it for my husband when he had the flu, and it worked. So, a good resource, very easy reading and easy to understand. Letitia, you have a question?
Yes. Oh, hi. Thank you, Dr. Cook. Like you are amazing. Like you're a godsend. I did get the book and I so appreciate it. I used some of the recipes, and one of the ideas she had in the book was to because I do smoothies almost
Hmm.
every day. And I had tried spinach one time and it kept making me sick. But what she did in the book is she like steamed the spinach and froze it and
Mm.
added it to the smoothie. That was just an amazing idea. But
Yeah.
one of my questions was like for doctors to access your publications. I'm pretty sure they know where to go, but where do they go to access your publications?
Do you mean like that last one that I showed with the data from Washington University?
Any of them. Like I want to talk with them about well, one, my
Oh,
gastroenterologist like kicked me out and they told me like it was a brain stomach disconnection, so it was nothing else they can do. And I was traveling like 2 hours away from my town. But now I'm seeing a gastroenterologist that's almost 5 hours away. And they do have a person on staff that would see somebody with gastroparesis. She specializes in it. And I just want to, the next one I have, I want them to be able to read some of your publications before they just dismiss me. Because one of
Oh,
my questions is I already have a feeding tube and my surgeon said my stomach is extremely scarred up. He don't want to go back in it because we had been talking about taking the feeding tube because he did take it one time and had to put it
hmm.
back in. Now he don't want to take it again because he said to go in and close the hole on the inside. He said my stomach's just severely scarred up. So with that being said, could I still get the gastric stimulator?
Well, that's obviously there's a complicated course here, and exactly what scarred up means, in the big picture, kind of all needs to be perhaps worked out or reevaluated. And I know that the Entero website and our patient liaisons, um, we have over the last several years created maps where there are like enterosurgeons and gastros who see patients like you. So it might be curious to look at the site and to see if there's somebody near you. Maybe you're seeing that person. I don't know. Because we're also reaching out, to doctors and um, MPs and nurses who take care of patients to try to help educate what's out there. And yeah, I think in terms of papers and this is exactly the educational piece. Patients today kind of have to be, uh, thoughtful, but a little more aggressive about their
Yeah.
care. And,
Yeah.
Yeah.
you almost have to bring in the paper yourself. I mean,
Exactly.
yeah, I
Exactly.
mean, but I think that our folks could probably, help you too, either online or that number. That's exactly what they do.
Okay.
And so, well, good luck. And yeah, by the way, that step two, smoothies and soups, you can get good calories in, and think of that. That doesn't take much milling. And as you sip through the day,
Hmm.
you can have a decent day
I,
because
I
you,
can tell you since I've been doing that and I've been focusing on more soups, my digestive system has been happy. Like I hadn't had that much nausea, still had some pain, but not that much nausea because the constipation is still an issue.
yeah, yeah. And most patients with gastroparesis don't have just gastroparesis. So many have constipation. So as you get that better, you'll feel better because that organ, the colon, is being attended to. And when diet does that much, that's really a diet as therapy. It's nutrition and therapy
Thank you so
because
much.
because you've realized, you might say, the limited work that your stomach can do. Most of us, we just pile it in and, oh, I overate, but I'll be better. No,
Mm-mm.
uh, you have such a different issue when it comes to nutrition.
Dr. Cook,
Thank you.
oh, thank you, Letitia. How
Thank you.
big an incision, 'cause this is a question I get as well, how big or small of an incision does it take to implant this device?
So, like with laparoscopic or robotic, you have these little puncture holes, so they can do the actual putting the electrodes in. Those are those puncture holes you all seen. And then there's about a, 2.5 inch incision on the skin where the device is actually, I have a little better picture here, I think. Do you see this? This is the device, and that is slipped into a pocket um, under the skin, and that's like the sort of 2 inch, 2.5 inch incision. Um, the others are the little puncture wounds, and then here you can see that's supposed to be the electrode in the muscle layer. Uh, so it's all quite tiny, um, and the stomach, that's the extent of the invasion of the stomach. The pylorus is not touched. That's cutting a valve. These are the electrodes position on the stomach.
So can it, when you're looking at the skin after you have this implanted, because this is another question I get, can you see it
No,
within the skin?
depending on, your weight, you may not see it at all. You can press on it and feel it below the skin. There may be a little bump in the skin, but where this is here, that's where the interrogator will like rest on that. And soon it'll be wireless. That can be
Wow.
interrogated. It can be interrogated with like an iPad type thing, and it can without placing this kind of device over it, so they can talk to each other. Okay, so that and see that, so the electrodes are there, and then these wires take it over to the where it's placed under the skin, like a heart pacemaker. But remember, is this a pacemaker? No, this is not a pacemaker.
We have thank you, Dr. Cook. We have a question from iPhone. I'm sorry, I don't know your name.
Is it me, Shane?
Hi, oh, hi.
Hi. Hi, Dr. Koch.
Hello.
I have gastroparesis, and I'm currently a patient of Dr. Conway's in Wake Forest. And we have noticed that my stomach has gotten worse, and the nausea, nothing is getting rid of it. And the Entera looks like this is something that we are exploring for my nausea and the vomiting symptoms. However, I have severe scoliosis with an S curve and have metal instrumentation all the way up and down my spine. Is that
Mhm.
something that would hinder me going through with Entera or looking at Entera as well?
Yeah, I mean, spinal issues, I have not seen anything in our literature about that.
Okay.
Those are bones, and as you know, and this is in the GI tract, and the GI tract is so flexible. It's moved around. Um, so nothing specific that I can think of, but I think as you when you get the referral to uh, if you're going down that track, your enterosurgeon will have to think about it as well.
Gotcha. Great.
Yeah,
Thank
yeah.
you.
Well, good luck. Yes, say hi to Dr. Conway. All
Absolutely. Thank you, Dr. Koch.
right, thank you.
Thank you.
I have
Can
one
you,
more question. Can I
oh,
ask?
yes, go ahead.
Okay, I thought of something. Okay, so does gastroparesis cause any kind of problem with the esophagus? And if so, would enterotherapy help the situation so the food can go down and not get stuck or feel like the food, whatever it is, solids, which I can't eat now, but with solids, like I feel like it gets stuck in my like going towards the esophagus.
Yeah.
And I was just told by my GI team at Stanford that they want to do like a whole lot of tests on my esophagus because the gastroparesis is not only getting worse, but they're afraid that because they think that the food is actually refluxing, coming back up. So I'm just wondering whether the gastroparesis might have been the cause for problems with my esophagus.
Yeah, that's a great question. And so yes, they can be related. That is, when the stomach doesn't empty, it's been known for a number of years. Well, in fact, 30% of patients who have reflux also have gastroparesis.
Mm,
And so say, what's the cart, what's the horse? But imagine your stomach's not emptying very well, so acid in food is sort of around longer.
mm,
And if that valve is not very tight, it may be a factor that's contributing to um, difficult to control reflux. So they can be quite related. But um, Entera is not indicated for reflux. It's going to be that nausea part of it. Yeah, and the esophagus, it sounds like it does need to be, it's being appropriately worked up. So your docs there will have to put that together.
thank
Thank
you.
you.
You're welcome.
Pam, you have a question? Of course,
Yes.
Pam always has good questions. Every
I don't know.
program.
This one is a little bit of more. I know you can't give medical advice, but I just had a two-part question. The first is I have very severe gastroparesis and I also have short bowel. I'm TPN dependent and right now I have a partial blockage in the small intestine, which no one will touch. Um, but they are talking about going down endoscopically and stretching with a balloon, trying to stretch open the obstruction.
Mhm.
So my first question was, I've been looking at Antera and also a G tube. M- Mine is, how do they decide what is better? What I do have reflux. I'm taking Zofran like candy, dicyclomine like candy, antacids. I have to sleep sitting up. I have constant vomiting. But how do you know whether the Intera is better or putting like in a G tube to dispel stomach? And then my second is, are there any physical restrictions with the Intera device?
Yeah. It's good questions. Yeah, you're right. You have a complicated case, and where Entera would fit in would kind of come down to, remember, we always go back to it was really indicated for nausea and vomiting. And then where's that nausea coming from? If the nausea is mostly up here and is it mostly a reflux nausea or is it really a stomach nausea? So your docs are still going to have to put those options together. But yeah, yours would be a complicated case, and not one of the more straightforward ones, um, where it's
Is
pretty clear that the problem is mostly the stomach and the nausea is the bigger issue.
Is there a doctor maybe in the North or South Carolina or Southern East Coast that you would recommend for Intera?
Well, I would have you, there are a number. And so again, our people
I'll
are
call.
are ready to help, you know, talk to you. There's some online things, but also these maps are available. And you might find somebody that's kind of near you.
That would be great. I
And
think I looked and I saw Duke was kind of the closest, which is where I'm getting my TPN treatment from now.
I see. Yeah. Yeah. Well, that those, as I said, those clinical decisions will have to be
Yeah.
kind of sorted out based on, I would think about symptoms and which one would help the symptom that bothers me the most. Uh, Once it's in, you can do about anything you want. I saw something about, I don't know about, bungee jumping and, you don't want to be
Yeah.
impacting the
Yeah.
stomach area violently. I don't think you want to play hockey, uh, take a
Yeah.
punch. So, do you know what I mean? So, except for those rather extreme-ish sports, I've had people who've been in accidents, where the seatbelt, traumatized those lead wires. Uh, they can be fractured, with but other than that kind of thing, you can do whatever you like.
You can swim
Shower,
with it.
bath. Pardon me?
You can swim with it.
Yes.
Oh, okay.
Yeah. It's all implanted. Nothing's outside the skin.
Thank you.
Yes.
Good
I have
questions.
one other question, please. Um, I was just wondering, is there a way like to turn on the, maybe, I don't know what you call it, but the computer pad or whatever it is on the outside to stop it for a day? Because there's a situation where I'm Jewish and we have a Sabbath every week, and I'm religious, and we're not allowed to like spark electricity. That's one of the rules. And so in order to even consider the enterotherapy, I was thinking, and my doctors were thinking how to work that out. So is there a way to do that? Is there a way to like like not unhook it, but like stop it from doing the like electrical stim and then turn it back on after the Sabbath's over? Is there a way to do that?
Well, you'd have to talk that through with your doctor, because you would have patients don't get to turn it off and on themselves.
Oh,
There's too many issues that have been seen over the years with stimulators. So if you worked it out with your doctor, you could go in and say, I want it turned off for religious reasons. But that you'd have to work that out. It would be a special visit because
uh-huh.
patients don't have control over on and off.
Okay. Thank you.
Thank you.
Good,
Yeah.
good question. Good clarification too. Is Martha here? I don't see her name. Martha wants to know when the next version of the Entera device will be available.
What's under development is an electrode that's easier for the surgeon to place in the stomach. What's under development is that device itself, I showed you a drawing of, that's going to be smaller and have a bigger battery. And that should be ready in about by the end of the year. So there are some, because the company got out of Medtronic, there is more going on to improve the product. But the insides, the actual controls, the actual stimulation, we know works at the levels I showed you. So yeah, but so there, if you've heard there's another version coming, it's more to be a little smaller and a little bigger battery.
Wow, that's great because we get a lot of questions on that battery. But you had clearly said that it depends on the intensity of it. So that
Yes,
can impact the battery life, which makes
that's
sense.
right. That's right. So, if your symptoms are controlled at a lower intensity of stimulation, that's good for everything, especially the battery. If it takes more, it takes what it takes. It's kind of like a drug. Sometimes you have to double the dose.
Excellent. Pam, do you have another question? You're muted.
Yes, I do. I just wanted to ask, I was looking at the studies and everything you have done, and what I was really taken aback was the percentage of how long it's been since they've come out with new medications, new treatments. And I was wondering, is there testing for gastroparesis? Are there new things that you're hearing about possibly coming out in the market, or even just a lot of the old processes and ways they would treat it have so many side effects? That's my question.
Yeah. No, over these years, the big pharmaceuticals have tried, and a lot of those drugs went through the full, they were safe in animals. They went through the full FDA uh, uh, pathways, but they weren't better than placebo. So they didn't get approved. They might have helped some people, but they were mostly to just improve the rate of emptying.
Mm.
Nothing about the other parameters.
All the other symptoms.
So I think we're about poised for a whole new way of looking at this, where the symptoms are coming from. And so right now, I've there's something coming out for motion sickness, nausea. That's more of a drug that works like an anti-cancer drug. I suspect doctors will try to use it in people with gastroparesis. But as I think you kind of understand, I think we should be doing a major reset on how we think about where the symptoms are coming from. But,
Definitely.
and I think but anyway, yes. Thank you for all those questions.
Dr. Cook, and thank you, Pam. You just put that slide up one more time for the people.
That
Yes,
one?
thank you. So, and Terra Medical has a wonderful website, by the way, with a lot of educational information. But to really connect with a patient educator, I think is such a great enhancement. Thanking Terra Medical for their continued support and wonderful work they're doing. And of course, Dr. Cook, always so humbled and grateful for all you do for us and for the patients.
Thank you.
So thank you. I close these programs the same way, but I can only speak from my heart. You are all my heroes. Dr. Cook, you are my hero. I think you're the hero to many patients as well. But I call you all my heroes, all of you patients, because you're the quiet heroes. You don't hear a lot about you. You're not publicized on TV as the greatest, latest star, actor, sports figure, whatever it may be. But every single day you're getting up in the morning, and it can be a struggle. And you can feel like, oh, I just can't go on, but you do. And that's the courage and the strength to get through the day. And to me, that makes you a hero, getting through the day. And be buoyed by the fact that you have wonderful people behind the scenes that are working to help you. Some terrific doctors, some companies like Intera Medical, who just have you in their focus to make your lives better. And when you feel alone, know that you're not, because my thoughts are with you, as are my prayers every single day of my life. And of course, my heart is with you. Don't hesitate to reach out. Our website is agmdhope.org. And you can always reach me by email, Mary Angela at agmdhope.org. Thank you all so much. God bless you all. Thank you again, Dr. Cook.
Yep.
Take care.
Thank you all. Thank you all.
Bye-bye.